कौन? सर्टिफिकेट दे दिया है? किसको?
नमस्कार होस्ट।
और ग्वालिनी जी मजे में हैं?
कैसे हैं सर?
मैंने वैसे मैथ्स का होमवर्क कर लिया।
सर गुड आफ्टरनून।
Good afternoon.
बॉस गुड आफ्टरनून।
Good afternoon, Ashutosh. Anand, Dr. Amit is there or not? Anand?
जी गुड आफ्टरनून सर। आई थिंक सर नो नहीं है सर।
अच्छा अच्छा, ठीक है, let him join. Minute or two.
संजय सर इज देयर।
Oh yes. Sanjay sir, good afternoon.
Good afternoon, sir. Good afternoon.
Actually,
So,
today Dr. Pradeep Mehta will not be able to join.
we may start now.
Yes, sir. If you permit, we can
Oh,
start.
sure. Hello.
दास सर 2 मिनट में सर ज्वाइन कर रहे हैं.
Okay, okay, okay. You are muted, Amit Dada.
Boss,
Hello.
good afternoon, boss.
Hi, good afternoon, Ashutosh ji. Welcome. And Davya bhai, good afternoon.
Yes,
Good afternoon, Amit.
Sanjay boss, good afternoon.
Good afternoon.
Uh, uh, I had talked to Dr. Tiwari sir. He said he'll join.
We must congratulate Amit for organizing a very nice ICP conclave on Sunday. Eh?
Thank you, sir.
It is very rare to see such a large gathering of around 300 people there. So many greetings and congratulations to you.
Thank you very much, sir.
जलवा
But I
जलवा
take
है भाई का.
inspiration from Darya bhai.
ये जलवा है भाई का. अमित भाई का
नहीं,
जलवा
वो
है.
तुरंत दरिया भाई से इंस्पिरेशन लेके करता हूँ.
Such
अरे
large,
बिल्कुल
वाह,
बिल्कुल
सही है.
such
बिल्कुल
large,
बिल्कुल
such large gathering is not
दरिया
even present
दरिया
in
साहब के नाम
press
ही में लगा हुआ
conference.
है से
I think we should stick to the time.
Yes.
Dr. Darya, may I request you to kindly start the proceedings, and may I request Dr. Sanjay to speak few words? Welcome.
Really, it is a matter of great pleasure for all of us to conduct this ICP short course series. So, without wasting any more time, I request Dr. S.S. Daria to kindly start the today's proceeding. Over to Dr. Daria.
Thank you so much, Sanjay sir, and thank you, Dr. Amit. So today's speaker is my good friend, my dear younger brother, Dr. Ashutosh Chaturvedi. He is presently working as an associate professor in Mahatma Gandhi Medical College, Jaipur, and today he will enlighten us on the topic of hyper-eosinophilia. So without wasting much time, I would like to ask Dr. Ashutosh Chaturvedi go for his presentation.
So, thank you so much, dear Dr. Daria boss. And at the outset, I would like to thank Dr. Kamlesh Tiwari sir, Dean ICP, Dr. Sanjay Kumar sir, Secretary Dean's Place, Dr. Amit Das boss, Journal member, East Journal member, API, and the course director, Dr. Sudhir Mehta sir, for giving me this opportunity for being a faculty in this very important session of hematology course. And today I will be discussing about hypereosinophilia. So I would like to share my screen here now. So just to confirm, is it visible and I am audible?
Yes, Ashu, it's visible and you are
Thank
audible.
you. Thank you. So now we will begin with the approach to hypereosinophilia, a very important and often neglected topic, because eosinophils, we at most of the times we neglect to see this parameter in the CBC. Just yes. So approach to eosinophilia. hypereosinophilia. So our objectives in this session are, we will deal with brief introduction of eosinophils, their biology, the terminology related to hypereosinophilia, etiology of hypereosinophilia, how to evaluate, and then hypereosinophilic syndrome, and then we will summarize the conclusions. So first of all, this is Paul Ehrlich, who was born in Germany in 1854, and he completed his doctorate in 1878 in medicine, and with the thesis on staining of animal tissues differentiates mast cells from plasma cells. In 1879, he discovered an important aspect, that is eosinophil, important part of the WBC series, which we will be discussing today. So he is the man who discovered eosinophil, Paul Ehrlich, and established the criteria based on cell morphology, physiology, and pathology to classify further hematologic malignancies. Now, with this, at the beginning of this session, the questions which came to our mind are, what are eosinophils? What do eosinophils do? What are the causes of eosinophilia? And why do some people develop problems from eosinophilia while some others don't develop? They hardly bother about what is going on in their body. So what are eosinophils? Eosinophils, let's go back to our MBBS curriculum at the start of the histology, anatomy, physiology, biochemistry, the things the first semester we read. So eosinophils are terminally differentiated cells of the myeloid lineage that is stained red with negatively charged eosin. They make up about 1 to 6% of white blood cells. They are granulocytes, contain granules. As you can see, there's a beautiful 3D diagram of eosinophils, 3D picture of electron microscopy. They are about 12 to 17 micrometers in size and have a half-life of 8 to 18 hours in bloodstream. The tissue lifespan estimated at 2 to 5 days, but it can be longer, up to 14 days. So half-life of 8 to 18 hours in blood and a tissue lifespan of 2 to 5 days can elevate to 14 days. Now, these cells are eosinophilic or acid-loving. Eosin means acid and philic means loving. So acid-loving, that causes them to appear brick red after staining with eosin. They are found in the medulla and junction between the cortex and medulla of the thymus. So important sites where eosinophils are found: thymus, lower GIT, ovary, uterus, spleen, and lymph nodes, though, but not in the lung, skin, esophagus, or some other internal organs under normal conditions. So under normal conditions, they are not found in the lung, skin, or esophagus, which are important pathologic sites. We will discuss further the pathologies of eosinophils, and in these, the lung, skin, esophagus are the important organs, but it is contrary to that eosinophils are not normally found in the esophagus. So coming to the development of eosinophils, eosinophils develop and mature in the bone marrow. They differentiate from myeloid precursor cells in response to the cytokines like interleukin-3, interleukin-5, and GM-CSF, that is granulocyte macrophage colony stimulating factor. As you can see here, the hematocytoblast is further divided into myeloblast, then progranulocyte, and progranulocyte gives rise to eosinophil, and that is a granulocyte. So it is bilobed. You can see here this bilobed nucleus. Normal eosinophil morphology contains of secondary granules, core and matrix. This bilobed nucleus, lipid bodies, which contains lipoxygenase, leukotrienes, EPO, and primary granules that are charcot-laden proteins. So this is the electron microscopy, a beautiful picture. You can see here bilobed nucleus, lipid bodies, sombrero vesicles, mitochondria, Golgi apparatus, all constituents of a normal cell of a human body. Now, what do eosinophils do? So it has been postulated that there are no reported cases of a congenital lack of eosinophils in humans. Humans, everybody, they have eosinophil in their body. Although eosinophil-free mice have been engineered in 2004, it was found that mice can have a eosinophil body, but the eosinophil-free mice appear normal but have altered responses to allergen challenge. That is obvious because eosinophil function is that, and effect in Helminth infection depends on that model, that schistosomiasis strongyloids, that we will discuss further. So what about humans? They cause host defense against Helminthic infection, anti-tumor effector cells, important for the reproduction, mammary gland development, importance in wound repair and tissue remodeling, MSC class 1 restricted thymocyte depletion, and modulation of the immune response, that is antigen presentation, cytokine secretion. So they fight the helminth colonization, that is the worm infestation. There are also eosinophils that play a role in fighting viral infections also, and they are important mediators of allergic responses and in the asthma pathogenesis. The abundance of RNAs that they contain within their granules and in fibrin removal during inflammation. So important in inflammation, worm infestations, allergic responses, asthma, and sometimes in viral infections also. So they cause the production of cationic granule proteins and possess neurotoxic, helminthotoxic proteins that lyse the helminths and certain viruses. They produce the reactive oxygen species and lipid mediators like the eicosanoids and leukotrienes, prostaglandins, enzymes such as elastase, growth factors, TGF-beta, VEGF, and PDGF, cytokines such as interleukin 1, 2, 4, 5, 6, 8, 13, TNF-alpha, etc. So these are the certain inflammatory markers that are produced by the eosinophils. So now coming to the pathological part, what causes eosinophilia? So eosinophilia is not an uncommon finding in our clinical practice, but sometimes, most of the times, it is an incidental finding. If it is associated with symptoms and signs of organ damage, can serve as useful clue for differential diagnosis. Now, peripheral blood eosinophilia, that is more than 500 eosinophils per microliter, may be caused by numerous conditions, including allergic, infectious, inflammatory, and neoplastic. Coming to the terminology, what is absolute eosinophil count, or sometimes also known as total eosinophil count? So it is number of eosinophil in peripheral blood. In the peripheral blood film, when you see the count of the eosinophils, it is called as absolute eosinophil count. And white blood cells count to percentage of eosinophils, AEC less than 500, or sometimes some labs take it to be less than 450, it is considered as normal. Eosinophilia is absolute eosinophil count more than 450 to 500 per microliter, and hypereosinophilia, it is absolute eosinophil count more than 1500 per microliter with or without end organ damage. So severity of eosinophilia, that is mild AEC between 500 to 1500, moderate it is 1500 to 5000 cells per microliter, and severe is more than 5000 cells per microliter. Hypereosinophilic syndrome. We will be discussing this hypereosinophilic syndrome in detail in further slides, but it is absolute eosinophil count more than 1500 cells per microliter on 2 occasions. And these 2 occasions should be more than 1 month apart, plus evidence of organ dysfunction, which is attributable to eosinophilia. So, hypereosinophilic syndrome, it is more than 1500 cells, 2 occasions 1 month apart, and organ dysfunction. Tissue hypereosinophilia, it is percentage of eosinophils that exceeds 20% of all nucleated cells in the bone marrow or tissue infiltration, and there is a marked deposition of eosinophil granule proteins in the tissue. So this is called tissue hypereosinophilia, when the percentage of eosinophils exceeds 20% of nucleated cells, these that are found in the bone marrow. Now, how this eosinophilia occurs? There are 2 mechanisms, clonal expansion and polyclonal expansion. So clonal expansion can arise in the setting of variety of myeloid neoplasm, that is acute or chronic eosinophilic leukemia, for example. And polyclonal expansion, it is mostly reactive, or we can also call it a secondary eosinophilia, while clonal expansion is also called as primary eosinophilia. So polyclonal expansion is due to overproduction of interleukin 5, and that occurs mostly like in asthma, allergic conditions, helminthic infections, while the clonal expansion, as I just spoke, that it occurs mostly in the setting of myeloid neoplasm. So tissue damage by eosinophils occurs when AEC exceeds 1500, but can occur with lower blood eosinophil levels also, and hence hypereosinophilia does not always result in organ involvement or tissue damage. So degree of eosinophilia does not always accurately predict the organ damage, because it can occur with lower absolute eosinophil count also. It is not necessary that hypereosinophilia always results in organ damage. So the eosinophil, the release of toxic granules, and they damage the epithelial cells and nerves. There is a release of lipid mediators, leukotrienes, platelet activating factors, that causes smooth muscle contraction, recruitment of inflammatory cells. There's a release of cytokines such as GM-CSF, TGF-alpha and beta, and interleukins, tissue remodeling and fibrosis. And the target organs of this damage are skin, airway, and GIT. As I discussed previously, that skin, lungs, and GIT, the eosinophils are not normal sites, but they are the sites of pathology. Whenever there is a damage, it occurs mostly in these three target organs. So what is the importance of absolute eosinophil count? It doesn't accurately predict organ damage because eosinophils are primarily tissue-dwelling cells. So this is a very important point. AEC does not identify the cause. It is severity of eosinophilia may help to narrow the diagnosis, but the AEC alone is not sufficient to make the diagnosis. For example, marked hypereosinophilia, that is more than 20,000 per microliter, can be seen in drug hypersensitivity or myeloid neoplasm. So drug at the one side, there is drug hypersensitivity, the condition which usually resolves in 2-3 days by simple antihistamines and corticosteroids, while on the other hand, the more than 20,000 per microliter eosinophilia can also be found in myeloid neoplasm. So it does not identify the cause, it doesn't accurately predict the organ damage. But unlikely in asthma allergic conditions, rhinitis or atopic dermatitis, it is not found that much of higher hypereosinophilia. Now, one another term that we usually write, you must have seen, we must have written ourselves also, that we write TEC-VEC. So what is VEC? VEC stands for vacuolated eosinophil count. They are a type of white blood cells, specifically eosinophils, that have small clear spaces called vacuoles within their cytoplasm. As you can see in this picture, this is the vacuole, that vacuole containing eosinophil, and they are often associated with inflammation, particularly in allergic or parasitic conditions, and are more likely to be found in individuals with severe allergic reactions and parasitic infections, such as in asthmatic patients. The VEC, vacuolated eosinophil count test, measures the percentage of vacuoles in eosinophils, and it is more indicative of severe allergic or parasitic conditions than the total eosinophil count. So, why we order simultaneously? Because if the VEC is elevated, you can assume that the allergic conditions or parasitic conditions the patient is having such type of disorder. Now, coming to the etiology of eosinophilia, it can be transient, it can be episodic, or it can be persistent. Now, transient eosinophilia is observed relatively frequently in the pediatric population and is generally clinically insignificant. What are causes of eosinophilia? As we discussed just now, that primary hypereosinophilia, that is clonal expansion, secondary hypereosinophilia, that is reactive polyclonal, and idiopathic. Third one is the idiopathic hypereosinophilia, we cannot identify any cause. So primary hypereosinophilia, it results from abnormalities within the bone marrow compartment that propagate the eosinophil clonalone, and the causes are mostly malignant, neoplasm, myeloid or stem cell neoplasm, and also in the minority of pediatric hypereosinophilia cases. While the secondary hypereosinophilia, they comprise of diseases that drive the polyclonal expansion of eosinophils by increased production of eosinophils, interleukin 3, 5G, and CM7. And the majority of pediatric hypereosinophilia cases are secondary hypereosinophilia. So coming to the causes of both classes, that is primary and secondary. So primary, mostly again, myeloid stem cell neoplasm, myelodysplastic syndrome, systemic mastocytosis, and the clonal expansion of eosinophil is there. In the secondary hypereosinophilia, there is polyclonal expansion, and the causes include infections, atopy, medications, GI disease, lymphocytic causes, immunodeficiency diseases, rheumatologic causes, and other important causes like adrenal insufficiency, sickle cell disease, graft versus host disease, solid organ transplant rejection, etc. We will discuss these causes further in detail. So this is the causes of eosinophilia broadly classified into infections. In the infection category, most common is the parasitic diseases. This is common worldwide, and the usual degree of eosinophilia is moderate to high. Bacterial diseases, we rarely found eosinophilia, and it is almost invariably the bacterial infections cause eosinopenia because there is neutrocytosis. Neutrophils are elevated. In some bacterial disease, there is lymphocytosis. So obviously, there would be eosinopenia, not eosinophilia. Now, in the mycobacterial also, it is mostly secondary to drug therapy. Otherwise, mycobacterial doesn't cause eosinophilia. Invasive fungal is also unusual. So mostly, there is parasitic infestations that lead to eosinophilia. In the allergic diseases, allergic rhinitis is very common. Atopic dermatitis, it is mild to moderate eosinophilia. While in urticaria, angioedema, or fungal allergy, it can lead to mild to high degree of eosinophilia. In asthma also, there is mild eosinophilia. Many drug reactions can also cause high degree of eosinophilia, and neoplasm almost always lead to moderate to high degree of eosinophilia. Acute eosinophil leukemia, chronic eosinophil leukemia, myeloid leukemia, lymphomas, histiocytosis X, solid tumors. Certain musculoskeletal conditions like rheumatoid arthritis can also lead to mild to high degree of eosinophilia, and occasional case reports have been reported, more usually due to secondary to the therapy of rheumatoid arthritis like DMARDs can also lead to eosinophilia. Now, eosinophilic fasciitis is also there. It is a severe condition. Excuse me. In the GI causes, the eosinophilic gastroenteritis and eosinophilic esophagitis are commonly seen. We have found that eosinophilia is a degree of mild to moderate degree of eosinophilia in these. Celiac disease, inflammatory bowel disease, allergic gastroenteritis sometimes is found in young children. In the respiratory tract, eosinophil granulomatosis with polyangiitis, chronic eosinophil leukemia, bronchiectasis, they can lead to moderate, mild to high degree of eosinophilia. Skin diseases include bullous pemphigoid, eosinophilic cellulitis, and certain miscellaneous causes like interleukin-2 therapy, hypereosinophilic syndrome, endomyocardial fibrosis, hyper-IgE syndrome, eosinophil myalgia, toxic oil syndrome, graft versus host disease. These are certain other causes that can lead to high eosinophilia degree of mild to moderate degree. Certain rare causes that includes a few syndromes are also there that can lead to eosinophilia. That's the Glick syndrome that is characterized by cyclic recurrent angioedema and elevated IgM, sometimes with clonal T cells. Sturge-Strauss syndrome, it is relatively common, and we almost or everyone has read about it, that it is the necrotizing vasculitis with eosinophilia. It is ANCA positive and ANCA negative subvariants are there in the Sturge-Strauss syndrome. Eosinophil myalgia syndrome is there, which is caused due to severe myalgia, and it is often accompanied by neurologic symptoms and skin changes also. Epidemic cases have been attributable to L-tryptophan exposure. That subvariant is also called as toxic oil syndrome. Then another one is the Omen syndrome, that is severe combined immunodeficiency plus hypereosinophilia, often with erythroderma, hepatosplenomegaly or lymphadenopathy, and autosomal recessive genetic diseases are there. In the hyper-IgE syndrome, there is hereditary immunodeficiency syndrome with hypereosinophilia and elevated levels of IgE, often with eczema and facial anomalies, known gene mutations, autosomal dominant variant and autosomal recessive variant, both are there in these. So what are the organ effects of these eosinophilia? It can damage heart, nervous system, lungs, skin, eyes, GIT, liver, muscle, and joints. So variety of involvement is there as per the degree of hypereosinophilia. In the heart, it can lead to constrictive pericarditis, endomyocardial fibrosis is very common, myocarditis, intramural thrombus formation, MR, TR, and coronary artery thrombi. In the nervous system, it can lead to mononeuritis multiplex, paraparesis, cerebellar involvement, recurrent subacute encephalopathy, seizures, meningitis, etc. Lungs, it can lead to fibrosis, effusion, pulmonary nodules, and pulmonary infiltrates. It can cause angioedema of the skin, urticaria, papillonodular lesions, mucosal ulcerations. Both buccal and genital ulcerations can occur with eosinophilia. Retinal vasculitis can occur. Microthrombi can be present in the eyes. In the GI, it is ascites, diarrhea, gastritis, colitis, pancreatitis, hepatitis, and nodules can occur in the liver. Destructive arthritis, effusions, and arthralgia, myositis can be due to eosinophilia. So these are certain damage events of eosinophilia. Now it is a very important slide. The helminthic causes of eosinophilia. Sometimes we can differentiate with the level of eosinophilia in the helminthic infections also. So there is marked hypereosinophilia, that is more than 3,000 or more than 5,000 per microliter in some helminthes infections, that is angiostrongyloids, ascariasis, clonarchiasis, fasciolosis, filariasis, hookworm, graphostomiosis, opisthorchiosis, paragnomiosis, cystostomiosis, strongyloids, trichinosis, and VLM. It can cause marked hypereosinophilia early sometimes, and mostly early in infection also. So there is chronic eosinophilia also, which is of several years duration, and it is found in cysticercosis, echinococcosis, filariasis, flukes like Fasciola busci, paragnomiosis, hookworm, strongyloids, dathostomiosis. So you can see a chronic eosinophilia in such type of parasitic infections. Unexplained eosinophilia, as more than 50% of cases of eosinophilia remain unexplained despite exhaustive diagnostic evaluation. So what we will do in such cases, we can try the empiric helminthic therapy as we usually do, or if the patient is really asymptomatic, it doesn't have, it is just an incidental finding, that we can lead to observe, wait and watch also in such cases. So after dealing with etiology, pathogenesis, now how to approach hypereosinophilia or eosinophilia. In keeping in mind, we must address two questions: that is hypereosinophilia primary or secondary, or is it secondary to a common and treatable underlying condition? And secondly, is hypereosinophilia in itself causing rapidly progressive damage? That is, it can be due to primary neoplasm of the bone marrow lineage. So approaching the patient, generally consider the patient's history part, past medical history, drug history, travel history, and family history. Both are important. Then go with the physical examination, detailed local examination, systemic examination of every system for finding any clue that we can contribute to the etiology of eosinophilia. Then information from the lab, and finally, if needed, imaging studies can be done. So discontinue all suspicious drugs possible, including herbal supplements. Withdraw any agent that is not crucial for the patient's well-being. Evaluate and treat parasitic infections. So detailed travel history is very necessary. Parasite exposure history is necessary. CBC, differential counts, peripheral smear, stool examination daily for 3 days continue. Sometimes may miss strongyloids, cystosoma, trichinella, filaria, toxocora in stool examination also. But there is additional workup, including serologic tests, that depends on the travel area where the patient has visited in the last few months. So general infectious workup with reported fevers and leukocytosis, chest X-ray, ECG, blood cultures should be done, sputum culture if the patient is having pulmonary symptoms, abscess culture, respiratory viral panel, Legionella urinary antigen, streptococcal urinary antigen, pulmonary consultation, GI consult for upper GI endoscopy if necessary, and infectious disease consultation for infection with atypical microorganism. So a specific workup of eosinophilia now: peripheral blood smear, routine chemistries, LFTs, aspergillus IgE level is important, total IgE level is important, serum vitamin B12 level, serum tryptase level that is elevated in myelodysplastic syndrome. It's a very important point, serum tryptase level that we often miss to investigate. Now, ANA and ANCA levels, stool, routine and microscopy, and sometimes ova and parasites. We have to order with this routine, specifically to watch for any ova or parasite if visible. HIV evaluation for underlying malignancy, if any, CT imaging, and bone marrow aspiration biopsy. Further additional procedures and diagnostic biopsy should be guided by clinical symptoms. That is, we have to go with the presenting symptoms and the system that has been involved with the eosinophilia. So this is the same, the laboratory investigations. If we are concerned for myeloid malignancy, we must involve an oncologist, and LDH, serum urinic acid, CT, chest, abdomen, pelvis, whole body should be done, then bone marrow biopsy. If we are concerned with organ-specific involvement, then tissue biopsy, wherever possible, should be done, and initiate therapeutic intervention as appropriate for most likely etiology. If the both things are unremarkable, no clear organ destruction or clinical manifestations are seen, then we must repeat CBC with differential DLC every 2 to 6 months and watch for any deterioration, if any, in the patient's clinical picture and examination also. So, what are the highlights of this till this now? So, this is the hypereosinophilia. Till now, we have discussed about the routine eosinophilia and hypereosinophilia. Now, coming to the most appropriate part, that is hypereosinophilia. So, what is hypereosinophilia? Absolute eosinophil count, as we discussed, more than 1500 on at least 2 occasions with an interval of 1 month, and or histologically proven eosinophilia in tissue, defined as what is tissue eosinophilia: bone marrow aspiration with more than 20% eosinophils in the aspiration film, histologically proven tissue infiltration of eosinophils by biopsy, or there is a deposition of eosinophil granule proteins. So this is hypereosinophilia. Now, what is hypereosinophilic syndrome? Criteria of hypereosinophilia, that is hypereosinophilia included plus these three, that is existence of hypereosinophilia as defined above, and eosinophil mediated organ dysfunction or damage, plus no other identifiable etiology for eosinophilia. So we have these points and we are unable to identify any other etiology for hypereosinophilia, and so it can be labeled, if the organ damage is there, we must label it as hypereosinophilic syndrome. So the three diagnostic criteria for this disorder: persisting eosinophilia, absence of another diagnosis to explain the eosinophilia, and signs and symptoms of organ involvement or damage are there. So that symptoms depend on the potential organ involvement. And we must have heard, all of us must have heard about Loeffler endocarditis. That is one of the most serious and life-threatening complications of hypereosinophilic syndrome. It can cause heart failure due to endomyocardial thrombosis and fibrosis. So this is the pattern of end organ involvement as per few studies in the hypereosinophilic syndrome. The cardiac involvement is 19.58%. Neurological involvement is almost equal to cardiac involvement. So major symptoms, major systems involved are the GI, that is 69.31% of symptoms, and dermatologic, cardiac, and pulmonary also 44.44%. This is from a study comprising of 188 patients. So this was regarding the definition of hypereosinophilic syndrome. Now coming to the classification of hypereosinophilic syndrome, there are a variety of classifications have been done in the past several years, but the latest classification that was valent in 2023 published that classifies HCS, hypereosinophilic syndrome, into 4 classes. That is primary, that is mostly neoplastic; secondary, that is reactive; familial; and idiopathic. So this is the chart algorithm of primary eosinophilic syndrome classification. So these are myeloproliferative forms. First of all, myeloproliferative features of myeloproliferative disease without proof of clonality. And secondly, this is CAL, that is clonal eosinophilia, that include the FIP 1LA and PDGFR positive fusion gene. It is called as fusion gene. So PDGFR fusion gene is there in this CEL. And coming to the lymphocytic forms, it is further divided with populations of T cells secreting eosinophil hematoproteins. So if the clonal T cells are there, T cells often exhibit an abnormal phenotype, immunophenotype. If there are no T cell clones are there, then the aberrant immunophenotype or evidence of marked T cell activation is there. So this is in the lymphocytic form. First was the myeloproliferative, second is the lymphocytic. Third comes the overlap, that is organ-restricted eosinophilic disorders. They are confined to organs. Then undefined, it can be benign, episodic, or others. In the episodic, there is cyclic angioedema and eosinophilia in the patient. In the benign form, this is asymptomatic, usually with no evidence of organ involvement. And in the associated HES, it is eosinophilia in association with a defined diagnosis. There is such as IBD or CSS. While in the familial part, this is a family history of documented persistent eosinophilia of unknown cause. So this is very important to understand this classification of hypereosinophilic syndrome. Now, This is further divided. How can we differentiate in the investigation part? So, in the eosinophilia associated with the fusion gene, the absolute eosinophil count is usually more than 600 into 10 to the power 9 per liter. While in the peripheral blood blast cells, they may be present or not. Bone marrow blasts more than 5% may be present or not. PDGFR gene is, yes, it is found. So similarly, in the chronic eosinophilia that is not otherwise specified, CL knows the counts are more than 1500. In the lymphocytic variant hypereosinophilic syndrome, also the counts are more than 1500. So this is important to further classify the primary eosinophilia causes. Now, some words about the myeloproliferative hypereosinophilic syndrome. There is the dysplastic eosinophils we can found on the peripheral smear. Serum B12 levels are more than 1000 picogram per ml. So these are elevated. Serum tryptase levels are elevated. There is anemia or thrombocytopenia. Hepatosplenomegaly is there in the patient. Either we can detect it clinically or by ultrasound. Bone marrow cellularity is more than 80%. So it is generally cellular spindle-shaped mast cells and myelofibrosis can be there. It is identified by FISH technique and RT-PCR of peripheral blood or bone marrow, and most of the patients respond to imatinib and they are typically steroid refractory. So second is the lymphocytic variant. Phenotypically aberrant T cell production is there in the peripheral blood, which is detected by flow cytometry. And there is clonal T cell rearrangement pattern by PCR, increased T cell production of eosinophilopoietic cytokines, particularly IL-5. So it is elevated in the lymphocytic variant. And there is history of atopy. These patients are steroid responsive and it may progress to T cell lymphoma. And the first line treatment is usually steroids. Third one is the Glick syndrome, that is episodic angioedema. This is mostly found in patients. They may develop detectable T cell clones and urticaria angioedema of the face, neck, extremities, and trunk is less often involved. It is an important point that trunk is less often involved. Weight gain with weight loss due to diuresis after steroid treatment. Fever, eosinophilia with infiltration and degranulation in dermis layer, elevated IgM, elevated serum IL-5, and the periodicity can be missed sometimes in the patients because of the intermittent steroid treatment or if the counts are only obtained when symptoms are present. Another one is the associated HES, that is recognized primary disorders associated with peripheral eosinophilia more than 1500 and most commonly as a result of immunodysregulation. Eosinophilia resolves with treatment of underlying disorders and complications of eosinophilia are rare. Familial eosinophilia, it is autosomal dominant and the gene mapped to chromosome 5q31 to 33. It begins at birth, but only a small subset can develop end organ damage or tissue damage. Lack of clinical manifestations is associated with a relative lack of eosinophil activation compared to other eosinophilic disorders. Undefined eosinophilic syndrome is also there. It is benign. Then some other class is the complex and episodic also. So in generally, it is prolonged asymptomatic eosinophilia more than 1500 per mmQ. Coming to the management part, it is aimed at suppressing eosinophilia and is initiated with corticosteroids. If patients are unresponsive to steroid, hydroxyurea or interferon alpha may be beneficial. Then IL-5 monoclonal antibodies like mepolizumab target this cytokine IL-5, which is elevated and which has a central role in differentiation, mobilization, and activity of the eosinophils. So for patients with prominent organ involvement who fail to respond to this therapy, the mortality is very high. It is about 75% after 3 years. So this is an algorithm. You can see the blood eosinophil count more than 1500. So first of all, we have to look for known causes of hypereosinophilia and also for eosinophil mediated complications of persistent hypereosinophilia. So if we will proceed, if there are features suggesting myeloid malignancy on CBC, there are blast cells, there is monocytes, anemia, thrombocytopenia, or some circulating myeloid precursors are seen, then go for bone marrow aspirated biopsy, karyotyping, cytogenetics like BCR, ABL gene, etc. And whatever is the conclusion, then treat as indicated and follow up and ensure that eosinophils are normalized. If the eosinophils are normalized, then it's fine. If the eosinophils are not normalized with the therapy, then go for the second line therapy and start the second line agent whatever is indicated in these cases. Now, coming to the other part, with the hypereosinophilia, if there are no suggesting features of malignancy on the CBC and peripheral blood film, then take the drug history, travel history, and risk factors for malignancy, parasite serology, stool blood samples, Ig, vitamin B12, all etc. should be ordered, and patient should be fully evaluated. If the underlying disease is found, then treat as indicated, add corticosteroids if rapid eosinophil lowering is needed, and follow up to ensure that eosinophils are normalized. If they are normalized, then it's fine. If they are not normalized, then evaluate for hypereosinophilic syndrome. And similarly, in the upper part also, if the underlying disease is not found, then evaluate for HES. Assess for HES variants, RT-PCR, and FISH for the FP, that is the fusion gene, FP fusion gene that we just discussed, and T cell phenotype, PCR for TCR gene, bone marrow biopsy, karyotype. So if it is the FP positive, that is FIP1L1 PDGFR fusion gene positive, then imatinib with corticosteroids can be tried if there is cardiac involvement, and treatment goal should be cytogenetic remission. If it is FP negative, that is the fusion gene is negative, then wait and watch. If asymptomatic, assessment for end organ involvement at regular intervals. Corticosteroids can be added and then can be tapered as per the response of the patient. And if the patient are non-responders, then we must go for second-line agents like rituximab, peginterferon alpha, JAK inhibitors, oncocarbide. So this is cyclophosphamide. So there is a lot of upcoming therapies are there for hypereosinophilic syndrome, and we need to discuss in details in another session. So what the point comes out after evaluation is that is there any need for urgent management? So by clinical status and levels of eosinophil, we can found that if the patient is acutely ill or extremely high absolute eosinophil count is there, we need to hospitalize the patient, treat the medical emergency, and evaluate, then simultaneously evaluate for the cause. If the patient is symptomatic but is clinically stable, then the level of eosinophils and clinical presentation should be evaluated, and it is the clinician's discussion that is clinician's discussion that should we admit the patient or not. If the eosinophilia is asymptomatic or incidental, then all such patients having more than 1500 per microliter absolute eosinophil count should have repeated CBC in 1 or 2 weeks to determine that eosinophilia is transient, episodic, or rising. Approach to incidental eosinophilia should be like that. For EEC more than 1500, evaluate for hypereosinophilic syndrome. For AEC between 500 to 1500, with no evidence of organ involvement, consider asymptomatic mild eosinophilia that must be present in either allergy or asthmatic asthma, or certain drug reactions. Drug medications can also lead to this eosinophilia. Now, exceptions for acutely ill child with eosinophilia, bacterial and viral infections typically cause decrease in eosinophil count. So fever with eosinophilia is a red flag in a child that should prompt consideration for other etiologies. So this is very important point. If fever with eosinophilia is there in child, it is a red flag. Eosinophilia urgency, we have already discussed it. Now, let us discuss in fast way that certain syndromes, the diagnosis you must have heard about DRESS syndrome that involves 3 criteria: drug-induced skin eruption, eosinophilia, eosinophil count more than 1500, and at least one of the following systemic abnormalities: enlarged lymph nodes, hepatitis, interstitial nephropathy, ILD, myocardial involvements. So DRESS is drug, rash, eosinophilia, and systemic symptoms. It is severe, potentially life-threatening drug reaction. Reaction begins 2 to 6 weeks after the initiation of the medication and may include maculopapular, morbidiform rash, high-grade fever, lymphadenopathy, lymphocytosis, hepatitis, and can progress to multi-organ dysfunction, renal failure, liver failure, interstitial pneumonitis, and is mostly it may be associated with HHV6 infection or reactivation, can be triggered by anticonvulsants, sulfas, NSAIDs, allopurinol, abacavir, nevirapine, minocycline, and dapsone, etc. Severe hepatitis is responsible for the majority of deaths associated with this DRESS syndrome. Treatment is as early as possible, stop medication and start steroids. So when to suspect DRESS? When skin eruption, morbilliform or diffuse, confluent and infiltrated is there, high-grade fever, facial edema, and enlarged lymph nodes in a child. Second is the hyper IgE syndrome, usually presents very early in life. It is inherited, autosomal dominant, autosomal recessive, and most cases are sporadic. Newborn with skin infection of Staph aureus, boils, pustuloexematous rashes are there, cold abscess, pyogenic pneumonia, pneumonia due to S. aureus. So this is a child with a typical X-ray showing pneumococele and left pneumothorax, patient with facial dysmorphism, eczematous dermatitis, and left chest wall abscess. Further lab investigation showed low CD4, CD3, CD8, and Ig levels with more than 2500. So there was facial dysmorphism, craniocytosis. These are the hyper Ig syndrome patients. The second is we already discussed Omenn syndrome, autosomal recessive, severe form of SCID, severe combined immunodeficiency syndrome, characterized by erythroderma, peeling skin, hair loss, chronic diarrhea, and failure to thrive, lymphadenopathy, hepatosplenomegaly, and elevated serum Ig levels. So there's a prominent triad of hepatosplenomegaly, lymphadenopathy, and erythroderma in the Omenn syndrome. Another one is the eosinophilic gastroenteritis, rare and poorly understood disorder, commonly affect gastric and small intestine. Eosinophilic infiltration can be seen in mucosa. Symptoms include nausea, vomiting, diarrhea, abdominal pain, GI bleeding, protein-losing enteropathy, malabsorption. This produce obstruction of the pylorus, and eosinophilic ascites is found. So it is non-specific presentation, most common presenting symptoms as already discussed, and presentation in infants can similar to pyloric stenosis that can lead to obstruction of the GIT. So peripheral eosinophilia, elevated serum Ig levels, hypoalbuminemia, anemia. Diagnosis is the mucosal form is most common, and it is identified by large number of eosinophils in the biopsy specimens of gastric antrum or small bowel by upper GI endoscopy. Similarly, there is eosinophilic esophagitis, dysphagia is there, food impaction, heartburn, and the esophagogastroduodenoscopy biopsy shows more than 15 eosinophils per hyperfield. This is also called as asthma of the esophagus, rings corrugated lining in 49%, and structures, esophageal structures occur in 40% of the cases. Diagnosis is there by evaluation for food allergy with the skin test and SGI. Monitoring has to be done every 6 to 12 months and with biopsy and esophagogastroduodenoscopy. Steroids, acid suppression with PPI, dietary avoidance of food allergens, and dilatation of esophagus is also done sometimes if needed in the eosinophilic esophagitis. These are the endoscopic picture of eosinophilic esophagitis. Erosion, distal narrowing, furrowing, trachealization, whitish exudate covering of the mucosa, and linear shearing. Another eosinophilic lung disease divided into idiopathic primary pulmonary eosinophilia, that is Loeffler syndrome, acute or chronic eosinophilic pneumonia, idiopathic hypereosinophilic syndrome, and secondary eosinophilic lung disease also that includes bronchopulmonary aspergillosis, vasculitis, or drug-induced. So they are diffuse bilateral alveolar infiltrates with somewhat lower lung predominance and positive spine sign that suggests a retrocardiac lower lobe infiltrate. It is called positive spine sign, and it is found in ABPA, a hypersensitivity disease resulting from immunologic sensitization to aspergillus antigens. It is seen in asthma or cystic fibrosis patients, and treatment depends on relieving inflammation. Systemic corticosteroids, antifungal agent itraconazole is important to decrease the fungal burden and diminish the inciting stimulus for inflammation. Serum Ig levels are also used as one of the markers to define the duration of disease. Then further classification and diagnostic criteria for ABPA is there. Radiologically, there is bronchial wall thickening, pulmonary infiltrates, and central bronchiectasis can be seen. So, dear friends, dear colleagues, respected seniors, to summarize, hypereosinophilic syndrome encompasses a heterogeneous and complex group of different subtypes within the wider group of hypereosinophilic disorders. Now, despite the increasing scientific research, interest recently shown in HES, several unmet needs in terms of pathobiology, phenotyping, and personalized treatment remain to be addressed. Also, the disease identification remains a diagnosis of exclusion, and the disease trajectory as well as prospective burden of non-malignant hypereosinophilic syndrome, and more generally, HE disorders is currently unknown. So the ongoing research will hopefully generate new evidence in the field, but in practical terms, shortening the diagnostic delay and time to appropriate treatment approach, it probably represents the most urgent issue in front of us. And even in light of the great impacts of HES, the quality of life of the affected patients should be improved. The availability of new targeted treatment recently licensed and marketed for the idiopathic cases of HES, they represent a further reason to focus on the early recognition of these patients in order to evaluate their eligibility for the first drug specifically developed for their condition. HES patients are hunting needs an overall increase in the general knowledge of the disease among all of us, all the physicians, clinicians who potentially encounter these affected patients, and a red flag based system might help in the recognition and referral of patients to the further specialist person. Dedicated healthcare pathways integrating primary care and hospital centers as well as facilitating intra-hospital referral should be consolidated. And besides site-related differences and organizational variables, approach of hypereosinophilic syndrome cases through a multi-level interaction and a multi-dimensional team approach is essential in our clinical practice. This is for all the students, all the PGs. It's a mnemonic, spectacle-shaped nucleus, eosinophil, immense immunology inside. So what are the causes of eosinophilia? To understand, to remember through a mnemonic, mnemonic is allergic. A for adrenal insufficiency, that is Addison's disease. L for lymphoma, all types of malignancies, Hodgkin's lymphoma. L for L-tryptophan deficiency, that is eosinophilia myalgia syndrome. E stands for eczema, allergic skin diseases, pemphigus, dermatitis herpetiformis. R for respiratory causes, allergic aspergillosis, ABPA, asthma, hay fever. G includes for the GI causes, gastroenteritis, eosinophilic gastroenteritis, and esophageal eosinophilia, etc., IBD, and etc. I for infections, mostly parasites and sometimes like fungi, coccidioides, immitis, and C for collagen vascular disorders like SLE, Sturge-Strauss syndrome. So remember, allergic for causes of eosinophilia. Thank you very much for joining this afternoon in this important session.
Dr. Ashutosh, that was a wonderful session on hypereosinophilia. I congratulate you on delving into details, a topic which is very, very less discussed in scientific platform. The lecture was exhaustive, but very informative, and you have not let any aspect of hypereosinophilia left. So these slides that you have made is going to be a great help to all the PG students who are in this session. Dr. Daria, please. Dr. Daria is muted. So may I request Anandji to unmute him? Meanwhile, we have few questions and yeah.
Yes, sir.
Daria Saab, please go ahead.
Excellent presentation, Ashu. Really,
Thank you.
you cover everything regarding the eosinophilia, and we know that in 10 years back, I was in ICU, and one patient came with a TLC of 90,000. 90,000. Then one of my residents said, "Sir, there is a sepsis." How you can say that patient was not having any fever, nothing, except the TLC was raised, it was 90,000. And once we sent the PBF, you believe the eosinophil was 68%. So that is why the reason our course director, Dr. Mehta, has been chosen this topic for all the residents and everybody because of so importance of this hypereosinophilia. Thank you so much. So I think, Amit sir, we can take questions one by one.
Yes, I can see in the chat box. If you allow me, I can rapidly discuss all these. So
Please
someone has asked, can specific biomarkers help differentiate between different HES variants? So yes, I have already presented a slide, and it will go into the detailed aspects of this eosinophilia, but there are certain biomarkers are there which I have been presented, and we can go through this slide also. It is available to differentiate between HES variants. So is there any role of IVIG? Yes, definitely. In some cases of hypereosinophilia, depending on the symptom and depending on the system which is involved. So in some cases of pulmonary, it is utilized. IVIG is also utilized. Then there is any role of Montelukast cetirizine in hypereosinophilia. So it is a very common drug that we always prescribe just when we encounter hypereosinophilia to stabilize the mast cells. The Montelukast function is to stabilize the mast cell, and yes, we can often prescribe that, but it is not the proper treatment. Then you have to evaluate properly, as I discussed in my slide, that our two concerns that should be there, that is the cause of eosinophilia is secondary or primary. So if primary is there, then it has to be rapidly evaluated because it is mostly a malignant cause. And if secondary is there, we can prescribe this supportive treatment like cetirizine, Montelukast, and all this. So role of DEC in hypereosinophilia, yes, in the pulmonary eosinophilia cases, in the fungal etiology also, we mostly prescribe the 21 days course of DEC, 100 mg thrice a day, and it is mostly curative in many of the milder forms of pulmonary eosinophilia. How many days to take eosinophils count to subside after taking anti-helminthic treatment? So we have to evaluate the PBF and CBC after every 2-3 months to take. And the important point is that whether the patient is residing in a prevalent area of this helminthic or not. If there is a travel to foreign history or another visit is there, then we have to rapidly evaluate the patient for the eosinophil count. So then last one is by Dr. Gwalani sir, how long to give anti-helminthic drugs and which drug? So these are the drugs, sir, we all know, albendazole, praziquantel, and these are the drugs, and all duration is specified. For stat dose, we give 3 HS doses usually, and then we evaluate as per the stool examination also, and also by the CBC and PPF. So these are the questions. The conclusive message to summarize is just that we have to firstly identify whether it is primary eosinophilia or secondary eosinophilia, and then second, that there are any symptoms or signs of organ damage. If the organ damage is there and there is markedly elevated hypereosinophilia, then it goes into hypereosinophilic syndrome, and then we have to further evaluate the patient, and if we are unable to do so, then as early as we must refer to a hematologist or oncologist.
So that was all about hypereosinophilia today. One comment was, where do we find the PPTs? Now all these recordings are being collected, and they would be released by the dean in appropriate time as per his comfort and planning. This would be available on YouTube, so you can very well see these videos on YouTube. And remember, you'd be getting the certificate only after completion of the 3-month course of SWOT certificate course. So that was all about hypereosinophilia. And I must thank Dr. Ashutosh Chaturvedi for a wonderful, fantastic class on hypereosinophilia, and to my friend and Dr. S.S. Daria for holding the program together like always, and to the entire team of postgraduate students and colleagues of ICP.
Thank you so much.
Thank you so much, Asu, and thank you so much, Amit sir. Today, Dr. Sudhir Mehta sir, father is not well, so he is busy there. So we pray for health of sir.
Right.
So thank you, everybody. So we can wind up now.
Yes. Thank you, sir.
Thank you.
Say goodbye
so
to all.
much.
Saying
Thank
goodbye
you.
to everyone. Bye.